Well, it's a wonderful honor to be here. I've never been to Vancouver. I claim proudly some roots to Canada, but it's sort of the middle of Canada, north of Toronto, where my grandfather came from. And he was a pretty, in the 1900 was first graduated from University of Toronto, and then he came to St. Louis, and that's how we got to the States. But proudly Canadian. And I didn't realize this wonderful city that you have here, and I can see why people don't want to leave. And wonderful academic program. Martin has been nice to us over the years in helping us do some research, but I can see he's going to be helping the whole world here. With, I think, Larry, you're behind it with your skills at facilitating things. So anyway, I'm going to talk about bladder cancer, and I've slant this toward the, of course, muscle-invading bladder cancer, and to how do we do in the older patients, for the following reason. This Phil Gray is one of our residents, and we linked up with the American Cancer Society and the National Cancer Database and all their big-time computers, and have had a couple of projects which are not terribly remarkable, except they're based on a lot of patients. And so here's a cohort from 2004, 2008 muscle-invading bladder cancer, which shows that the median age at diagnosis is 72 years, and of course that means that half are older than that, and even the newly diagnosed patients 80, a quarter of them of muscle-invading bladder cancer occur in patients that are 80 and older. So it's a bad disease, and it happens in a population that has a lot of comorbidity, as you well know, I'm sure. And this is just another way of looking at it, with showing that that there is a there shows 84% at having a little trouble with a mouse here. I've got too many mice or something. I think I probably can't use the pointer very well, but it's all right. I think I'll be fine. So, what are the patterns of treatment of these patients newly diagnosed with muscle in the States? And so, using this cancer database, we've been able to address that. And the thing that is a little surprising, but I think it's been reported in some other cancers, that if you declare curative therapy for muscle-invading bladder cancer, either requiring cystectomy, in some instances maybe partial cystectomy, or radiation as part of the treatment, radiation to a dose that I think is able to eradicate the cancer. Certainly not all of them, but at least a dose of 50 gray, 5,000 sonogray or rads. Then it turns out that of all patients diagnosed, 35% are not getting that. Now there are some that are getting a TUR and followed that way, and that may be appropriate for some patients that are older, but generally not done. Even Harry Herr and other people do that in a very narrow minority of muscle invading. But when you get up to be over 80, 60% are not getting curative therapy. And this just plots the cystectomy rates by age. And the thing that I think is important here is that it really starts to fall off, so that even the 70 to 80s in our national population, only half of those patients are getting cystectomy. As you get, only about 2 or 3% are getting radiation in the younger age. This bumps up to a little bit less than 10% in the 70s and up to maybe 15% in the 80-year-olds. But so it's still this huge number of patients that are not getting what we would call curative therapy. And this is the use of these two techniques, predominantly cystectomy, by the various types of centers. A community center is one that in our databases sees a very low number of cancers across the board a year, not just bladder cancer, just a low number of cancers. And as they get more, it's really based on size. And of course, the teaching hospital is one with a residency program, and then we have less than 20 of these designated cancer centers. So as you get into the more skilled or whatever bigger, the cystectomy rate is higher, of course, but it's counterweighted by really what's happening in our communities. And if you do one of these forest plots, which is a clever way to do it, I think like the English say, it's a sort of too clever by a half. But if you just look at the white population, you see that the odds ratio underutilization is really in some of the minority, but also importantly, unfortunately, I guess, that if you take as a the relating patients, those that have private insurance, then of course they take them here. You see that everybody, with the exception of older Medicare, also don't get as frequently aggressive therapy for the bladder cancer. That actually, I was a little bit surprised to see that also is the case for breast cancer in our country. So we have I think we all knew it, but in a way we have a pretty well-defined unmet need to improve the low rates of potentially curative therapy for these patients. And so then I want to address today how safe and effective is this technique that has become, I think, pretty clearly better than radiation alone, a trimodality therapy with chemoradiation and TUR. And of course, there are only 2 randomized trials, the first of which, by 20 years, was by NCIC. And a small trial, but it did show, using the original Yagoda regimen of 100 milligrams per meter squared of cisplatin every 3 weeks, that it combined with radiation, that there was a significant reduction in the recurrence rates in just 99 patients. And there have been many randomized trials of cisplatin plus radiation in head and neck, lung, gynecologic cancer, but there's no other bladder trial in that area. But obviously cisplatin was a big drug, and then it didn't seem to have many competitors, so it just stayed, and we've certainly stayed with it. I think maybe a little too long, because in the UK, where they see a lot of bladder cancer, and they use radiation in the elderly a lot. This, I think you were aware of, this trial that uses the regimen of chemotherapy that has been used to radiosensitize patients with anal cancer very successfully, so that mitomycin C 5FU. And so Nick James and his group in the Midlands were able to test this before the year 2000 and showed that it had real activity in their population, and so they began this randomized trial, which I'll report, but I'm sure you know about it, 360 patients. And it's an impressive randomized trial, and I think it shows that there are other drugs, and certainly gemcitabine is another one that deserves some testing as well. But how does chemoradiation work in the elderly patient with cisplatin, which we've been stuck on since really the mid-80s? This is our own database of, we've treated patients on protocols continuously, and everybody who was entered and started this sort of trimodality approach is in this database, whether they finished it or not. But I just bring it out that this is the general population with now 348 patients, and it's comforting that there are very few late events beyond 5 years, just as there is with cystectomy, and that it really stays up there at about 60% out to 15 years. So I think we are not suffering from a lot of late recurrences. But if we look at it in the patients that are 75 or older, which is a minority of our patients, we had you see that the disease-specific survival is not affected, but of course these are patients who are selected with creatinine clearances that are adequate to take cisplatin, so they're not It's a little bit like you use for your cystectomies. You don't treat everybody by cystectomy, but if it's a young 75, you do, etc. But their kidneys have to be pretty good for the cisplatin part of it, as you're experiencing, I think, with your wishes to do neoadjuvant chemotherapy in this population with a lot of comorbidity. The RTOG, our national, and it's really Canadian, it's North American group, has done these cisplatinum-based protocols that we similar, of course, and we've been very much involved with that. But they also, in the older population, have noted that so long as they meet the criteria for creatinine clearance, they apparently do as well with disease-specific survival. So it's a good thing if you're able to make the cut for getting cisplatinum. And so I think that, I mean, using cisplatinum, those with good renal function, shouldn't be a lot of hesitancy or shouldn't be limited by concerns of reduced disease-specific survival, even in the elderly. And it seems to be maintained, and it doesn't fall apart after 5 years, which has been the main concern, I think, of the thoughtful urologists and caregivers in bladder cancer, that maybe it just wouldn't hold up over time. But I think that that's not the case. So bladder preservation in the elderly. What about using drugs that are a little more user-friendly to the patient, maybe not to the tumor, than cisplatinum? And so we really were blessed, I think, by the work from the UK and ferreting out that 5-FU mitomycin was tolerated in the older patients, which they're seeing. So they in 7 years ran off 360 patients with a median age of 70 years and almost six years of median follow-up, and just published it last year in the New England Journal. It was basically a pretty straightforward situation where half got their radiation dose, which was 64 gray, and the other half got that plus 5-FU and mitomycin C, the program that the English and we use in North America for anal cancer. And this is a slide that Nick showed. He came over to our SUO a couple of times, but anyway, he was just showing what they were doing. He just wanted to use this slide to point out that for the English MCV neoadjuvant study, and I must say for Bart Grossman's SWOG study, the median age for that was 64, but the median age for this one is 72. And this is just for the medical oncologists and you that have had experience with mitomycin. The English use just 1 dose of 12 milligram of mitomycin C, and the American approach has been to use 2 doses separated by 4 weeks of 10 milligrams. And the reason I bring that out is that now I don't treat anal cancer, but the people that use this regimen in the States, some of these patients end up with pretty compromised bone marrow. But in the English study, where they just use the 1 dose of mitomycin, you'll see I think they get good results with their combining it with radiation, but they don't have that long-term toxicity. And so, as we're in the process of trying to change our ways for patients that are older, we're using this regimen. And this was just some side effect things, early 6 months toxicity with and without this regimen. Really wasn't terribly toxic, and it wasn't increased by the use of this drug, which is not probably at all effective against distant metastatic disease, but has been adopted there. And as I say, it's put the abdominal perineal resection pretty much on the shelf for anal cancer, although I think that it's used maybe 10 or 15% of the time for failures. And this is their looking at local invasive, meaning T1 or worse, recurrences. They've cut their recurrences in half, and now with a 6-year follow-up, it seems the curve split nicely at about 2 years, but also it looks like it's being maintained in their program like it is in ours, so that it's an impressive figure, and I think in our risk of being a little bit of an overstatement, but I think this has been a sort of a game changer, that it works in older populations, and prevents the need for cystectomy in a vast majority of patients. They do use the salvage cystectomy, but not as much because they don't have to. So that the advantage then, I just getting ahead of myself, it seems to be well tolerated in the UK, even with patients with a lower moderate renal function. It's certainly proven as well as it, I think, can be, as better than radiation alone. And they only have 11% cystectomy rates in the treatment arm with chemoradiation, and that their median survival, overall survival, not disease-specific survival, is 48% at 5 years, which is, by clinical staging, that's as good as any series there is. So I want to just cover a couple of things which I think you all are probably well appreciate, but anyway, we like to point out that we are misunderstood slightly, I think, about how this program works, and that we want to make sure that any misconceptions are addressed. And so one is that the bladder is not worthless when you get through with it. Perhaps people that use the old actinomycin D in children or something like that, where you really do have serious late effects, which of course aren't used anymore. Even in rhabdomyosarcoma of the bladder, they use other drugs than actinomycin D, which is a huge normal tissue radiosensitizer. But just using the quality of life instrument, really, Bob Crane helped Anthony Zeitman with this, and Jim Talcott was our Boston quality of life guy in urology back then. But anyway, with our studies using urodynamics as well as questionnaires, 78% of the patients had really compliant bladders by urodynamics. 85% had really no urgency in questionnaires or occasional urgency. And somewhat to our surprise, questionnaires, 50% of the men had normal erections. So I think there have been other studies, but that's one that patients we treated. Now, if you look at sort of doctor-reported side effects, not patient-reported side effects, you can talk about toxicity. And so we looked up 157 patients who we treated on RTOG protocols, Jason Estafio and myself, and our statisticians in the RTOG. And we chose patients that the bladder was preserved and that we had at least 2 years of follow-up, because, as I'm sure you all know, it can take some time for radiation harms to blossom, as you will, to show themselves. And so we have a median follow-up in this group of 5 years. It's not as long as the one that Anthony Zeitman did with us, but it's still pretty long. And there's really a low rate of significant, there are no grade 4 or 5 toxicities, and it's 6% of a bladder or urinary toxicities and 2% GI. So we don't have a big problem harming the bowels, surely, and we don't have much. It's mostly hematuria related, and we broke it down. This was sort of a median cut point for us, but we're trying to get it for the older population now. But if you look at the cumulative incidence of those grade 3 toxicities over time and split the population between 65 years younger and older, you see that there's it's not different in either one. So it doesn't seem to be uniquely toxic in the period, and it's not more so in the elderly. So we think that acceptance of this modern bladder-sparing chemoradiation and TUR should not be limited to concerns about high rates of late pelvic toxicity, even in the older population, which I think is good news. And then this other misconception is that this whole thing happens without the urologist being involved. Well, that's just not true. So there are 3 major areas where I think the success of our program is manifest. And one is the aggressive maximal TURB at the beginning, and then we give a dose that was based on the really probably on the old pre-op radiation dose of 40 gray, and in our case in these protocols cisplatinum, and then the urologist reevaluates the patient, and if the biopsies are positive at the tumor site after this treatment, then it goes right on to radical cystectomy, salvage cystectomy, and I think this is a very important part of our program. We clearly pick up cures in this group, and then of course, just like you would do for non-muscle invading bladder cancer, if you treat it conservatively, the urologist is really the fulcrum and is doing the frequent cystoscopies, etc. So it's nothing further from the truth that that the urologists aren't involved. And so just one slide that I use our own data here we had good information on the quality of the TURB in 340 patients, and if you look at the ones that our urologists felt were visibly complete or not, it's about 2 to 1 were visibly complete. And the important thing is if you're interested in obviously in curing the patient, but if you can safely avoid cystectomy, you see that if there's been a complete TUR done, we avoid we undergo cystectomy about 20% of the patients. That doubles to 40% in the patients that don't have what the urologist feels gross residual disease is left. Now, some of that, of course, is staging, the smaller tumors, etc. But I think it just shows the importance, if you can, of doing that. We have many patients alive who didn't have a fully debulking, and 40% required backup or salvage cystectomy. But it's not required, but it certainly is a very big component. And I don't think anybody would treat a breast cancer these days if you couldn't do the lumpectomy beforehand. I mean, you do, but I mean the inflammatory cancers. But it's all part of the program. You get that taken care of. Yeah.
So if you've got a relatively large sessile bladder tumor that is not possible to be resected by TUR, and you still have a palpable induration
right.
mass, is that patient excluded from your protocol?
Yes and no. I mean, it depends. If cystectomy is a possibility in that patient, we will not often. I mean, it's a little hard to get accurate diameters of bladder tumors. Our urologists kind of use the 6 or 7 centimeter diameter, or more than a half the hemisphere. I mean, of tumor. But yes, if we can't do a really substantial debulking, we think that we're going to do less well, and maybe we shouldn't bother. But they always try, and they're getting quite aggressive. They're certainly quite aggressive, even on the tumors that are right near the UV junction, and they don't. We've had only one perforation. Significant. That wasn't retroperitoneal or whatever. But yes, so that's and hydronephrosis. I'll bring it out in a minute, but hydronephrosis is a contraindication. So you have to be selective. Yes, Dr. Sullivan.
Do you make use of a second resection in some of your cases, like Barry urged?
Yes, the only ones that don't get a second resection, and they're a minority, are those that come directly to our urologist with blood in their urine, and they set about to help the patient. And if it's in the cards, and when they're in the operating room, they're deciding they might want our program, which usually is pretty high on their list. They'll do an aggressive TUR, and that's it. But I would say we get over 80% of our patients from patients that come into us for this procedure. So yes, so we're getting 2 TURBs, and we find it's the right thing to do. I mean, you all have patients that have come from other centers, and they say, "Oh yeah, we did a complete resection." And that was 4 weeks ago, and you go in there, and there's a lot of tumor. So, yeah.
If the second resection is negative, how do you manage that?
Right. So we've been following the tenets are really of our urologists. George Prout was our leader, but we generally do not. I know Harry represents about 10% of the patients that Harry does this. If he doesn't find any significant cancer on the second go round, he watches them, but we generally don't. They go in our program. So we feel insecure not treating them, and we don't have too many harms, so that's what we do.
So that 10% are in your...
Absolutely, yeah. We can't find them more than the way I've explained it. We don't have a way. And then, of course, the importance of salvage cystectomy from the urologist participation. These are 102 patients that had a radical cystectomy, either because they didn't make it on the early checkpoint of a complete response, or because they recurred later with an invasive tumor. But these are, there's a very significant cure rate here. It runs about 40% or a little bit higher at 10 years of disease-specific survival. So this is about as well as you do with cystectomy for T3 tumors, really. So it's a very important. Of the ones the 70% that don't require a cystectomy, we have an overall cure rate of disease-specific cure of over 10%, over 70%, or 75%. But even the ones that aren't responding to our treatment or recur, cystectomy cures something about 45% disease-specific survival. So the urologists, of course, are really the fulcrum of everything that we do. We've looked up the patients that I think almost all of those 102 that failed in our series had cystectomies at our hospital, but not all. But one of the urology residents, Dr. Suara, with us, looked up the complications using the Michel Donant Memorial Hospital sort of modified system of labeling surgical complications, and we've compared them their complications in less than 90 days to the primary cystectomy rates at the Memorial Series, which is much bigger. And our complications are not strikingly worse. They may be slightly worse in some categories, but generally they're not a lot worse. And we've been lucky in that way. So that the problems with our approach, I mean, it's just the way it is with clinical care. I think obviously, like you do for non-muscle invading bladder cancer, there's lifelong surveillance is required, cystoscopic surveillance. The risks of salvage cystectomy may be increased where we have a fair bit of experience doing it, and we do it with almost always an ileal conduit, not a neobladder. The salvage cystectomy rate may have increased side effects, but not much. And others do neobladders. We talk about it with the patients, but relatively few of our surgeons feel that they want to do the neobladder in previous radiated patients. But we certainly had patients go back to USC or other places and get neobladders. And so those are the three problems. And then these are I think, Martin, you were driving at this, there's certainly patients that aren't appropriate for our treatment, and if you have conditions which make radiation of the pelvis not safe, like ulcerative colitis or prior pelvic radiation, or a tumor that can't undergo a major debulking TUR, maybe one hiding in a diverticulum, I think you would not want to address one of those. And then if their bladder isn't working very well in the first place, no real reason to save it. So those are some of the contraindications, but they're the major ones. And one other one that is the hydronephrosis. We were the first to show that was a bad predictor of outcome. I just think it co-varies with tumor size, and I don't think there's anything unique about the tumors that grow around the UV junction. So the truth about this approach is it should be used selectively. Its use is approved selectively, like we said, in about both the NCCN guidelines and the EAU guidelines. At least 2/3 of the bladder is going to be spared. The bladder functions well, and the patients want it and seek it. They have to be, as Adam Kybell says, and it's well expressed, the patient has to be motivated. In other words, they have to hang around getting treatment for, a better part of 6 weeks, and it's in some ways it's, I don't think it's surely not more toxic, but it just the patient has to be willing to put up with all that. The side effects are not terribly bad, but the investment of their time is shorter than it would take for an uncomplicated cystectomy, surely. And this is just our national now, and there are a couple of Canadian chapters now, but the advocacy network, and they're alerting patients selectively that when they or their families inquire about the possibility of bladder preservation. So we're gaining a little traction. This is our muscle invading bladder cancer protocol for RTOG that's now open. It's actually we probably complete accrual in another year or two, but we wanted to compare, and I'm a little disappointed since I believe I was responsible for this, the comparative arms. But we wanted to use the Michigan regimen, which was once-a-day radiation and gemcitabine, because it doesn't require the high level of renal function, and once-a-day radiation is a little easier than twice a day, although it takes a little longer. And we compared it to our other best arm, which was 5-FU cisplatin in previous protocols. But if we were really on the ball, we would have paid closer attention to what Nick James was doing in the UK and had that as our comparator arm. We would be, I think, a little further ahead. But we don't. Anyway, that's what we're doing now, and it's accruing quite well. And we spoke last night, that would be able to be opened here, and actually Canada, Hamilton and other centers, Edmonton and Princess Margaret, they've contributed quite nicely. But I want to just say one thing before we finish up. I want to do just a little in the translational research. There have been a couple of breakthroughs, not just the 5-FU mitomycin chemoradiation program, but some things on translational research. And the National Bladder, the NCI, our NCI, has a task force on which I serve, and they're trying to promote translational research. And so we've come up now with I think a pretty legitimate phase 2 study, which will probably be opening in about another 12 to 18 months. And it's based on this 5-FU mitomycin in the elderly. But these are some of the people on the protocol committee and various subspecialties, urology, Mark Schoenberg and Adam Kybell, and then medical oncologists, and that David Quinn, as you know, is at USC, and so it's a big group. And we proudly use Dan Theodorescu, who I point out is Canadian, as one of our translational researchers. But it's going to be open not just in RTOG but all protocols. And the reason that we're interested in this is there are these developments which are not terribly profound, but they're helpful to this approach. That there are many elderly patients not receiving radical cystectomy, that 5-FU mitomycin is tolerated in the older patients. And then most recently is that there's not just one but 2 reports identifying one of these DNA repair proteins, MRE11, expression as predicting for success with radiation and success with chemoradiation, but not with cystectomy. And then, of course, the Bladder Task Force and are interested in promoting clinical trials. This is the first one that was shown from Leeds in Manchester, where the cohort that was the high expressors of MRE with radiation alone did significantly better, and it didn't make a difference one way or the other with cystectomy, as you might expect. And then there was a confirmation of this in a separate data set published by the group in Aarhus, Denmark, where they looked at the cystectomy cohort and didn't seem to matter, of course. But again, in the radiotherapy, majority of which is cisplatin-based chemoradiation, there also was improved disease-specific survival. So we have two. It's really quite a potentially exciting, another way to predict who, or help you select who might be benefited. So we've sort of not gotten along as quickly as I'd like, but so the specific aim of our new protocol is to correlate the level of MRE expression in the tumor with the treatment responses to this regimen, and we need to define a cut point or some threshold, like in breast cancer, HER2 new expression of 2+ or 3+. We hope to be a little more quantitative than that. We'll see how we do. And then the protocol that we've set up is a pretty straightforward protocol. It's for patients that are or aren't cystectomy candidates, and so they get the 40 gray, and they're going to use we're going to use the British technique. And if they go there and at 40 gray, and as we expect 70% will be biopsy negative, we'll just carry on with the regimen down to 65 gray, and then the long-term cystoscopic surveillance, and if recurrence, cystectomy if they're candidates. If the biopsy is positive, then we know these are not going to be highly, I mean, a few could have their bladder preserved, but if possible, we should change. And so if they're a cystectomy candidate, those will go to radical cystectomy. Thinking among our committee is that maybe patients of not particularly suited for cystectomy will go into this regimen. They are absolutely train wrecks, and you couldn't possibly operate on them without, a heart transplant or something. But if they fail, since there's such a good cure rate, I think there's going to be some of those. The urologists are going to, with the cardiologists, get together and find a way to maybe. So I think we will have the backup cystectomy a little bit more than we think. But if not, we're going to change the chemotherapy for the last bit to gemcitabine, which is being tested and is an effective agent. So that's our approach, and we just plan to correlate CR rate with 5FU with this approach and prospectively and get a cut point. We're using a lot of other help with other forms of translation research to try and identify other, and we're doing some sequencing also with the Memorial Group, I think. And then we look at quality of life, particularly in the elderly. So that I think the case for chemoradiation in the elderly is that it saves lives, it's better than radiation alone, it spares at least 70% of the patients from major surgery and has relatively little toxicity. And so, not overstating anything, but I think now chemoradiation can be recommended as one of the better and safer curative therapies for elderly patients. And I think we're making some headway there, and so we're glad about that. At dinner last night, I asked if I could show about 5 more slides on a little bit more controversial, or there's controversy, to say the least, to what do you do with your T1 tumors that recurred following BCG. And so we've developed a protocol which is accruing poorly in RTOG. It's a limited space, of course, for using chemoradiation as conservative salvage. Doug Dahl is the lead urologist on it, Dora Michelson, in medical oncology. And so I think it's true that this is a group in which you can, at this juncture, they failed BCG treatment. You can treat them perfectly, or you could over-treat them one way, or you could under-treat them another way, and it's controversial, and there isn't a whole lot of guidance except that the safest thing to do is to take out the bladder. Which is the standard treatment, surely, from guidelines around the world. And when you do, you're going to cure 80% or so of the patients, not 100%, but it's going to be the propitious moment maybe to play that card. But I mean, there are other things, and there are more coming along. Michael O'Donnell and others are doing a lot, but none of these seem to work too well, the intravesical therapies, and with even 2-year follow-up, generally poor responses if they fail BCG, if they have a legitimate course of BCG, not a poorly administered one. But we looked up some few years ago when I got interested in this area. In our series, we came up immediately with 18 patients that had BCG and failed. They had the BCG for non-muscle invading cancer. They failed, but they came to us when they failed for the first time, I guess, not always. But they had muscle invading cancer. So how well did they do with our program? They'd failed BCG, and we got them at the clinical T2 level. And the answer is they did really pretty well. Median follow-up of this group is quite long in terms of reporting patients in this space. Only one has required a cystectomy. At 7 years, 10 free of any bladder recurrence, and the disease-specific survival is 70% at 7 years. So we don't harm the bladder by this approach, and it seems like it would be useful for patients who aren't, for you to consider for patients that aren't perfect for your cystectomy. And so the goal is to evaluate the cure rate of this approach while preserving a well-functioning bladder. But the main eligibility criteria is, I think, an important one. It's that you all feel, participating urologist judges, that next standard treatment would be to take the bladder out. But this protocol could be used as an intermediary where we think the need for cystectomy will be markedly reduced. It's a little different regimen. Still, obviously, urologist is the key player, but we don't take a break. We just go through to 61 gray and use the chemotherapy, and the same follow-up. We treat the whole bladder because the whole bladder is at risk. Surely the whole bladder gets the whole dose. We also treat the pelvic lymph nodes to 40 gray because we know that there's about a 15% chance they'll be positive. So the chemotherapy started out to be our cisplatin regimen, but we found that there were patients that we were getting referred that couldn't have cisplatin, so we opened it to 5-FU mitomycin, and we're hoping that will increase our accrual. We only need a little less than 40 patients because we think it's quite likely to, at least with short follow-up at 3 to 5 years, to work in well over 70% of the patients, and we're setting a goal if we can achieve 60%, that would be somewhat clinically significant. So when we think we don't need that many patients to have that lower bound. So that's where we are, and that's what we're projecting our success, and that's another protocol that we could open in RTOG if you had thought you might get a case or two a year for us. So with that, I'd like to thank you all for giving up a very important part of your day, keeping you from the operating room, but happy to discuss this new approach, Larry.